All right, we're going to get started. Welcome back, or welcome anyways. I'm Carlin Center in Primary Care Sports Medicine, and it's my pleasure to introduce Dr. Jeff Berry. Dr. Berry is an orthopedic surgeon here at UCSF who specializes in hip and knee replacement surgery. He cares for patients with all types of degenerative conditions of the hip and knee, as well as for patients with complications from prior joint replacement. Dr. Berry's research interests include perioperative management and risk assessment, revision surgery, and the management of complications after total joint replacement, and educating the next generation of medical students and residents. His current projects include studying how to best manage infected total joint replacements, as well as the implementation of technology to improve outcomes and enhance the patient experience. I'm thrilled to welcome Dr. Berry back to our conference this year. Many of our patients have questions about what to expect with joint replacement surgery, and I know that we'll all be super well prepared after his talk. So please join me in welcoming Dr. Berry.
All right. Thanks for having me. We did this last year too, and it was really fun. I prepared a bunch of slides that have questions that patients ask, but kind of last time it very quickly devolved into just a kind of organic question and answer. So if you guys have questions at any time, please just raise your hand. You don't need a mic. Just kind of say it loud enough that I can hear it and I can repeat it, and we can kind of go whichever direction we want. But just to get things going, let's go. I don't know if you could pull the slides up. There we go. Oop. All right, so sorry, I clicked a few slides. So these are my disclosures for this. There's nothing relevant to this. We get some support for our fellowship from some companies, but not really showing anything pertinent here. I'm a Bay Area native. I grew up in San Jose, then went to Duke for undergrad and been back at UCSF for pretty much everything except for fellowship. I went back to North Carolina, but I've been here for 7 years as a faculty member. This is our group of arthroplasty surgeons that's kind of always growing. So you may hear our names with some of your patients, but we're a group of 6 people that just does hip and knee replacements and then hip and knee replacement issues and fixes for those. We now have clinics kind of all over the Bay Area. So wherever you guys are at in the Bay, there's an arthroplasty surgeon and a clinic close by. I practice in the city and then also in the North Bay with a clinic in San Rafael and operate at Marin General. You can see we're also in the East Bay and in the Peninsula. So these are kind of how I split up some of these questions, kind of topics about basics of hip and knee, some random stuff, the perioperative period and recovery, and then long-term after hip replacement, knee replacement, what to expect. So just some basic questions. So when you're replacing a hip or a knee, what are you actually doing? This is seemingly basic, but sometimes people don't quite understand this. So arthroplasty, arthro just means joint, plasty means reconstruction. And so basically what we're doing is replacing the disease surfaces with prostheses, and that's either metal, plastic, or ceramic. And this is a really high impact intervention. They talk about this being the operation of the century. I would put the outcomes from total hip up against pretty much any intervention in medicine. They also often talk about the qualities or the quality adjusted life years that you get from a hip replacement. And it's neck and neck with cardiac stents, and that's because you obviously don't have any life adjusted years if you don't have a stent and pass away. So that's how powerful a hip replacement can be for people. This is kind of what it initially started looking out like. John Charnley was kind of the godfather of hip replacements, and they called this the low friction arthroplasty. It's kind of a cemented implant with a polyethylene liner. This was after they tried everything from Teflon to ceramics to glass, and all these things kind of failed miserably until we kind of got to this iteration in the 70s. This is a more modern hip replacement, what it looks like. The components are a metal socket, a metal stem, which is the part that goes in the femur, and then a ball made out of some sort of ceramic metal or a ceramicized metal, and then a plastic liner typically. Most of the hips are fixed with cementless fixation, which means that the bone's going to grow into it. It's kind of porous like bone and mimics bone, and the bone doesn't see it as non-self and just grows into those holes in the metal and then bonds on. Sometimes in older patients, we will use cement, which is like a grout, to kind of hold it in place if the bone is too soft. And this is kind of what it looks like when it goes into a patient. The black there would be metal and ceramic, and then the bone around. In a total knee replacement, it's kind of similar. What we're doing is also sort of a resurfacing of the joint. There's 3 compartments in the knee, like you guys know, medial, lateral, and then the patellofemoral compartment. In a total knee, we're doing the total knee, so medial, lateral, and patellofemoral. There's 4 main components to a knee replacement: the metal on both ends of the bones, and then the plastic in between the two, followed by a piece of plastic under the kneecap as well. Fixation of most of the femurs in the U.S. is with cement. In contrast to the hips, we usually cement these in place. There's about 30% in the U.S. that are now done cementless, and that's kind of a growing group, but most of these are held in place with cement. And this is kind of what that looks like in a patient after they've had a knee replacement. So what are the implants made out of? I kind of talked about this a little bit, but this is a huge thing for patients for whatever reason. I don't know why they really care that much, but they really want to know what these metals are made out of, what's in them. The majority of implanted materials in the hip are titanium, so that is the main component. So people with nickel issues, whatnot, usually not an issue in the hip because titanium is a fairly pure alloy in the replacements. And then the ball is usually made out of ceramic or something called oxinium, which is a zirconium product. With knee replacements, there are kind of more, historical issues in terms of what they're made out of. Most of the implants can't be made out of titanium because titanium as a bearing is too soft. And so that part on the femur that's touching plastic would be damaged or nicked or dented too easily if it was titanium. So we do use harder implants made out of cobalt chrome. These do have some nickel in it. There has never been any this is a big thing for patients that they have jewelry issues with nickel, and then if they have a knee problem, they assume that that's related to the nickel. There's never really been much of a correlation between internal issues with nickel and cutaneous issues with nickel. A lot of studies in that in orthopedics, and kind of the bottom line is probably doesn't matter. But for patients that have nickel issues, there are implants that can be nickel-free. Any questions about that stuff? You can just keep going through these. Yeah.
So if there's no cement used in the acetabulum,
yeah.
how is it attached? Do you screw it in, or it just like clicks in?
Yeah, that's a great question. So when we're doing the acetabulum, the socket side of a hip replacement, how does it stick in if we're not using cement? So we kind of use this cheese grater, grouter looking thing called a reamer that makes a perfect hemisphere. And then we take a perfect hemisphere made out of metal that's a little bit bigger than the hole that we just made. And so it's an interference fit at its most basic. The lucky thing about the acetabulum is that it doesn't see much shear stress. So once it's in there, there's not much resistance between the ball and the bearing. It's not actually seeing much load that's going to kind of knock it loose. So it's actually a very, very stable component, and very rarely do sockets come loose. Usually if there's an issue, it's because of an infection or because of plastic wear and other problems. So we can put screws in them. We don't always. You can see that example that I showed didn't have any screws in the socket, but that press fit is just from the size of the implant is a little bit bigger than the bone hole that we made. And the bone has a little bit of a modulus of elasticity that kind of stretches around the implant and just kind of latches onto it.
And then with the knee, are you going to talk about the ligaments? What do you do with the ligaments?
Yeah, we can talk about the ligaments. So in a knee replacement, let's go back here. So in a knee replacement, if you see the kind of on the left side of the screen there, the ligaments in the center, so the ACL and the PCL, are typically sacrificed during a knee replacement and replaced with the mechanics of the prosthesis. The ligaments on the side, the MCL and the LCL, remain, and they stay there. So those ligaments on the side are very important, the MCL in particular. A lot of a knee replacement is kind of balancing those ligaments and making sure that they're nice and happy throughout the range of motion. You can still get injuries to those ligaments even after a knee replacement, same as you can get injuries to muscles and tendons because all those are still your own. But the ACL and the PCL are gone in a knee replacement. So patients that have deficient ACL does not matter for a knee replacement.
And then did you cut them? Like to get the replacements in there, what about the patellar tendon?
So to get a knee replacement in there, we are going around the side of the extensor mechanism. So quad, patellar tendon, and we're going, it's called a medial parapatellar arthrotomy. So we just go on the medial side of it, kind of move the kneecap off to the lateral side, do what we need to do, and then close that arthrotomy back up. Yeah. The extensor mechanism of the quad, kind of going down a rabbit hole here, but that's the biggest thing after a knee replacement that people have to rehab and get back. So the extensor mechanism takes a huge hit just from immobility, from the surgery, from swelling, and that is typically the longest thing that comes back. So when we look at knee replacements and say, how are you doing? It's typically quad related. And when we look at the duration of recovery, we tell most people it's about 3-4 months, you'll be back to doing most of the things you want to do. That's not the end peak of recovery. The end peak of recovery is 1 year, 2 years, and it all comes down to kind of muscle strength and quad usually. Good questions. Okay, so when are people candidates for joint replacements? This is a good one. So when to choose a joint replacement is typically you have to meet these things. So you can't just have arthritis on x-ray. That's not a reason to have a joint replacement. You have to also have failed non-operative treatment. You have to have pain that's kind of limiting you from doing the things that you want to do. You have to have a decrease in your quality of life, and you have to have x-ray evidence of arthritis or joint or cartilage issues. Usually patients are telling us when it's time to have a joint replacement, not the other way around. So just because they have a bad x-ray, I'm never going to operate on someone that has no pain, no issues, or is hiking Kilimanjaro and all these things with arthritis. That's not a reason to get a joint replacement. So arthritis, I keep just saying that disease of the cartilage, just catch-all term for anything that's making that cartilage disappear and the bones start to touch. There is no way to make cartilage come back, despite what any of the booths out there may tell you or other people. There is no way to make cartilage come back that we know of. We can grow cartilage in a petri dish. We cannot grow it with enough of its friends and attach it to the right places to restore a joint in a weight-bearing surface. So once it's gone, but that doesn't mean that you can't control the symptoms. And so that's a lot of what kind of non-operative care is controlling the symptoms. So arthritis, kind of think of it like a road, starts off nice and smooth and paved. You start getting cracks in the cartilage, then you start getting big potholes, and then the whole thing just falls apart in a tsunami warning. This is kind of what the joints look like in really bad cases. So top left there is a femoral head that's come out. Cartilage, it should look like a cue ball. Like when you're playing pool, it should be perfectly smooth and white. You can see it's very kind of lots of irregularities, a lot of kind of these eroded areas. You can see in that bottom left picture, that's kind of a little joint mouse, the little joint loose bodies that kind of form. The cartilage knocks off, and that's like a human pearl. The body kind of wraps it up and puts it in different places. And then this is a really bad knee. This is kind of showing you what we do to do that exposure. You can see the kneecap is off to the far side there, and we're staring into the knee joint. But big surgery, right? Knee is a big surgery, big operation. Usually incisions about 15 centimeters in front of the knee. Hip replacement we can get down pretty small now, usually 8 centimeters or so in the front of the hip, but the knee is still a big incision. So things that cause arthritis can be wear and tear. That's kind of a misnomer. It's not actually wear and tear, but we just tell patients that because we don't know why they get it. It's just kind of a disease of aging. But you could be a marathon runner and not get arthritis. You could be a couch potato and get arthritis. Other ways that people get are inflammatory diseases. So RA, psoriatic, spondyloarthropathies. These are higher risk populations when they're having surgery just because they have more medical problems. They're often on immunosuppressants. They're on different drugs that kind of can affect their recovery. Prior trauma is another big one. So if you've had a fracture or an injury, and this can include less severe trauma like athletic injuries may kind of add up to an earlier development of arthritis. And then AVN or avascular necrosis is the most common reason we're doing hip replacements in young people. Can be from a bunch of different things. Typically it's steroids, not like anabolic steroids for weightlifting, but steroids for medical treatments. And then childhood diseases, this is less common in people born in the U.S. Because people catch these early, but a lot of immigrants will often have some of these severe developmental dysplasias that have just been neglected and come in with some pretty terrible problems. Any questions about that stuff? Yeah. BMI requirements. Yeah, good question. The BMI thing, I think it was the New York Times or one of those came out with an article recently about BMIs and joint replacements. People with high BMIs have higher risks of complications after joint replacements. There's no doubt about that. So the higher it goes, probably related to the metabolic syndrome and the metabolic issues, the rate of infection starts to skyrocket pretty exponentially. That kind of skyrocketing starts at a BMI of about 35. Most joint replacement practices in the U.S. have a cutoff of around 40 to 45 as when we start saying it may not be a good idea to do a joint replacement right now. So at UCSF, that is our kind of soft cutoff is 40. It's not one size fits all. Some people will start at a 60, and if they've lost 100 pounds to get to a BMI of 45, we're not going to tell them no, they've done a good job, we'll kind of do it. But someone who has kind of no skin in the game, hasn't tried at all, we'll usually have them try to lose some weight. There's a lot of good data coming out right now on the Ozempics of the world and the outcomes after joint replacements when you've lost weight with them. And people who have been on them do much better than those that have not. So again, going back to the kind of metabolic issues, probably will be a big thing in the future is kind of those being prescribed for maybe these patients who weren't joint replacement candidates in the past. Very good question.
And that's because of risk, like post-operative, or does it
all of the above. So perioperative risk is the biggest worry. The kind of worst thing that can happen to a joint replacement is an infection. So if you get an infection or prosthesis, the bacteria gets on the metal, it does not come off. It's there for the rest of the patient's life or until that metal comes out. So you have to do all kinds of things to clear the infection. The best way to avoid it is just not to get an infection in the first place. So a lot of preoperative optimization goes into choosing who can or can't have joint replacements, or trying to get people as safe to do so as possible. Just when you're counseling patients about the importance of weight loss, one of the things we always go back to is if you get an infection of a joint, your chance of dying in 5 years is the same as if you just got diagnosed with lung cancer. So that's how bad it is if you get a joint infection. So we try to avoid those. Yeah, sorry, did I answer your question? I feel like I went off on a thing.
Do you treat post joints with prophylaxis for short-term variables?
We try to have them not do dental work for the first 3 months. And so the first 3 months after surgery, we think of as a very high-risk window. You got a lot of blood flow going to the joint, a lot of healing happening, blood going into a space that is normally immune privileged. So a joint is usually separate from the rest of the circulatory system. When you got bleeding and healing happening, that's not the case. So we don't really want transient bacteremia happening. So anything, whether it's colonoscopies, dental work, other surgeries, if they're elective, they shouldn't happen for about 3 months. In our practice now, most of us after 3 months say you don't need anything. It's not a big deal. The bugs that cause joint infections are not typically oral flora. Now, that's not to say it never happens, but it happens every time you're flossing your teeth, so it's not really something that can be controlled of forever, the bacteremia from the oral flora. Yeah.
So also, when you have a large patient that you don't want to do it because it's also more difficult to actually do surgery, get to the area you need to get to?
I mean, it is more invasive typically. So a lot of times the incision matches the depth of the field. So it is a more invasive surgery. That's not typically why we would be saying no to somebody. I mean, there may be subconsciously a degree of that, but that's not why we're saying no. We're saying no because we don't want to create a patient who has a 25% risk of getting a PJI or a periprosthetic joint infection. So you get a BMI of 60, those risks start getting off the charts. That it's almost not if, it's when they're going to get an infection. So it's a little bit paternalistic, but that's kind of, it's 100% the infection, yeah. The other things like, the other complications that can happen are higher rates of things like fractures, loosening of the implants, wear of the implants. That does happen at higher rates, but those are usually more controllable problems. Infection is the one that we just can't really control very well. Yeah.
Sorry.
Yeah.
One more thing,
Yeah, keep going.
Do you ever do replacements, either knee or hip, when there isn't pain, but there is instability?
Rarely, yes. So The reasons for that would be very nuanced. So sometimes if someone has let's say post-polio or something of that nature where their knee is getting they have no quad and their knee's getting so weak, a lot of people with polio will start to back knee, right? Their knee will just keep back kneeing and they start stretching out and going farther and farther and farther, and then they just can't walk anymore. So a lot of times in those situations, we'll do things for functional reasons, but typically the primary reason for joint replacement would be pain. There's a lot of people with kind of terrible looking joints. They don't move very well. If it's not affecting their quality of life, they can still move around. They're not having pain. We're not going to touch it, but there are situations where we will do with no pain. Usually a long discussion, though. It's not usually the first time I meet someone, they're like, let's do this. Let's kind of get to know each other a little bit. All right. Good. Is anyone too old to get a joint replacement? This is something that we run into all the time. People are getting older, more active. They come in all the time and they're like, I got an x-ray with my primary care doc. They said I have arthritis. I'm worried if I wait, I'm going to be too old or I'm going to be too sick and I'm not going to be able to get it. So let's just do it. And those are a lot of people that were kind of talking off the cliff there, that if you're still active, you're still doing all these things, you're still healthy enough to have a joint replacement, there's no reason to do anything prophylactically because there is always risk with these procedures. So as long as they're doing the things they want to do, they're not waking up in the morning and deciding, I'm not going to do that because my hip hurts or because my knee hurts, I'm not touching them. Or we may say, like, if it's slowing you down just a little bit, let's try some of these non-operative things first. So I did an elective hip replacement in a 97-year-old 2 weeks ago. There are some super active 90-year-olds. They do really well. So this is not something that is a big surgery in that regard anymore. If you're living independently, you can walk up 2 flights of stairs, you're getting more mets than we're stressing you in a surgery. Yeah.
Have you found for the older adult population where just the anesthesia risk is higher, that a lot of them are willing to do spinal, like your knees?
Yeah. Yeah, our default is to do spinal. So all of our joint replacements are done with spinal unless there's a reason not to, for partly that reason, that it is very low sedation, minimal cognitive side effects, little stress on the heart and lungs. If anything, it's kind of like relaxing for the heart and lungs, taking stress off of them. So that spinal anesthetic, kind of some of the periarticular injections and things that we do for pain control, it is a very well-tolerated physiologic procedure now. Yeah. Another big thing has been the advent of this drug called TXA, or tranexamic acid, which happened about 10 years ago. We started using it. People just don't lose that much blood when we operate anymore. It used to be that blood loss was a huge physiologic stress, and now it's about a can of Coke is about the amount of blood that people lose from a joint replacement now. Yeah.
When are you too young?
Another good question. When are you too young for a joint replacement is the other question. We don't love to do it before skeletal maturity. So that's the kind of short answer. The youngest I've done is 13. It's usually AVN or some of these other issues with where the femoral head just dies and collapses. Typically it's around either sickle cell or some sort of cancer treatment or something of the history of infection or something that killed the head. So it's very rare, but we try to wait until they're skeleton mature. But yeah, good question. Yeah. Yeah, no, keep going.
Regarding the tranexamic acid, have there been any studies yet on the VTE complications since that was?
Yeah, one of the nice things about joints is that we do millions of these a year, and they're almost all the same, so we can study things like that really, really well. Never been any increased risk of DVTs after TXA. TXA is a thrombolytic, not prothrombotic, or an antithrombolytic, not prothrombotic, so it doesn't increase your risk of clots. We use it in pretty much everyone except people that have had very recent stents. That's pretty much the only contraindication now. All right, keep going. Okay, so this is random stuff that people ask about. What about stem cells and other injections? I think you might have gotten a little bit of a hint of what I thought about these. But non-operative management of OA, these are some of the big guidelines from some of the arthroplasty societies. And you can see, kind of just put this on here, not to read it, but just that there's not really any certainty or any kind of clarity for a lot of these things. You can kind of find a paper to support whatever you want. But in terms of a lot of these non-operative interventions, there's kind of, I'm going to kind of break it down into more of like what's safe and maybe works to what we should avoid. So these are things that I think in people are pretty safe and pretty proven. They have benefit. They should at least be tried in most patients. And that's things like weight loss. So we know weight loss helps a lot. Takes force off the joint, makes the joint not see as much stress. I love these force diagrams of knees especially. 1 pound is 5 pounds to the knee when you're going down a stair or something. You lose 5 pounds, you took 25 pounds off your knees back. So those are easy kind of things. You tell people lose 5, 10 pounds. Those are doable goals. Other things like physical therapy and activity modification have been shown to be impactful. Correcting muscle imbalances, stabilizing things like the knee should at least be tried. And switching to low impact activity often will keep people going for longer without having to go through a joint replacement. And then the last thing would be NSAIDs or Tylenol, anti-inflammatories. We use these a lot, and if it wasn't for the side effects, we'd probably put it in the water. Meloxicam works really well. That's what I prescribe most people because it is a COX-2 and it's a little easier on the stomach. But you just got to be careful about kidney stuff. You got to be careful about long-term use in cardiac patients. Gels are another one, plus minus for the knees. Some patients love it. And then the other thing would be gait aids. So this is something that patients hate, but they actually work really, really well. So a cane is great for arthritis. People get huge relief from a cane or a walking stick. Don't use it like Dr. House. It should not be in the same hand as the bad leg. It should be in the good side. So put the cane on the good side and mirror the bad leg. It's very easy to show someone how to do that correctly. You put 15% of your body weight through a cane, you reduce the joint reactive force by 50%. So that's a huge stress off of a knee or a hip. Injections, these are the things that we use in our practices. Steroid is just an anti-inflammatory. My kind of cynical view of this as kind of the end treatment pathway is all these are probably working in similar fashions as an anti-inflammatory. So hyaluronic acid, PRP, steroids, stem cells, the ways that they're working are probably all through anti-inflammatory pathways. It maybe gets to those places a little differently and maybe has different side effect profiles, but that is probably the crux of it is anti-inflammatories. I try to use injections sparingly in normal joints, okay, especially steroids. Steroids have been shown to be, they may hasten the loss of good cartilage. My argument would be, why are you using steroid in a healthy joint? But if they already have arthritis, you can use steroids all day long, every 3 to 4 months, as long as they're working. You're not saving anything anymore. If it doesn't work anymore, we're cutting it all out anyway. HA and PRP are probably a little safer and more normal looking joints because they don't have that same cardiotoxic effect. Whenever you're injecting these, if you are going to use a diluent, please don't use lidocaine, use ropivacaine. Ropivacaine is a much less chondrotoxic drug as opposed to lidocaine and some of the other ones. For knees, there's great evidence for cortisone, pretty much equivalent evidence for HA. PRP is usually matched against HA and not against other things in most studies, and PRP does pretty similar to HA in most studies. Again, the cynical part of me would say that that's because they don't want to go against steroids because it might lose, but they work well, they're safe. There's a cost to PRP, so just be cognizant of that for patients. Most insurers will not cover PRP, but they will HA and steroids. And for hips, there's never really been a lot of good data for hip injections. They just don't work as well for whatever reason. So we usually only use those in diagnostic purposes. We don't use them to kind of as a long-term treatment strategy. In arthritic patients that have kind of stage 3, stage 4 arthritis, the average is they get about 3 weeks of relief from a steroid injection in the hip. So not the same as kind of knees and shoulders. Yeah.
Would you inject a patient with a partial arthroplasty?
Yeah, that's a good question. The question was, would you do an injection in a patient with a partial knee replacement? Sparingly. So the reason being that we don't love putting needles in to replace joints. It goes back to that infection thing. It would be incredibly rare for an injection to cause an infection. But when you have a partial knee replacement, that's metal in there. Every time you're putting a needle in there, you're kind of asking for something to seed. So we will do it sometimes, but again, it's usually sparingly. Sometimes, again, in that diagnostic category, like is it the other compartments that are causing you problems? We'll use an injection to see if that'll make the pain go away. Yeah. If anyone does get an injection, it's 3 months before you can have a replacement, and that's 3 months from that joint. So if you get an injection in your left knee, can't have surgery on that knee for 3 months. That's for an infection reason as well. Yeah.
For young patients, especially those who have autoimmune diseases, where you're trying to limit their maybe lifetime exposure to steroid injections in the knee, like, what do you counsel on if you're, say, it's like a 30-year-old who's fairly athletic, like, how do we try to limit this or spread this out?
Yeah, 30-year-old and fairly athletic. I'm assuming you're saying they have some arthritis or some issues going on.
Psoriatic or yourself.
Those are tough ones. I would tell them to use them in situations where they really want to be in their optimum. So say they got a vacation coming up or they got something where they got to be good, save it for that. Those patients are not the ones that are really young with the inflammatory that we want to be doing every 3 months. We kind of start that every 3 months. Like you can keep doing them if they're working for like patients that's like, if it doesn't, we're doing the replacement the next 3 months, right? So if you're 30 with a knee problem, we're trying to stay away from replacements a little bit. So I would steer them more towards the HAs of the world, the PRPs. I didn't put this in this talk, but there's some increasingly used things called geniculate nerve ablations and some of these other procedures that we can sometimes do for pain control that maybe are good temporizing measures. But yeah, steroids, try to stay away from them long term if you're going to try and keep that joint. Yeah.
Would be
Okay.
great in the future where post-toe joint or post-toe knee will be able to run and do activities like that without any restrictions.
I don't restrict any of my patients now. The question was, will there be a point where joints don't have any restrictions afterwards, like being able to run, things of that nature? So hips in particular, go crazy. Do whatever you want to do. People can get back to doing whatever they want to do. They can run, they can be on a bike, they can do triathlons, and they do. The new plastics and the new bearings just don't wear out anymore, which is fantastic. So 15 years ago, they came up with this thing called highly cross-linked polyethylene. Doesn't seem to wear out anymore. So those same patients that had it 15 years ago, we take x-ray, plastic is exactly the same. So now we kind of let them do whatever they're able to. Knee replacements, just they could do the same, but they just don't usually ever get back to that same level of confidence on the knee is probably the issue. Yeah, it's not mechanically that they couldn't run. It's just more of the confidence on the knee is not the same. When you lose that kind of proprioception on the end of the joint, it just doesn't have the same cutting, pivoting feel. Whereas a hip, you don't need that. So people are generally more able to get back. But there are people who play basketball. There are people who run on knees. More common, though, would be things like biking hundreds of miles, hiking, swimming, pickleball, tennis, things of that nature. Yeah. Bupivacaine, where it stands. Was that the question? I think it's in between lidocaine and ropivacaine. I don't remember the exact study, but there was one of my co-residents when I was in training did this whole thing on, I think it was rabbit joints or something, and the only one that was actually not killing all the joints was ropivacaine. So that would be what I would use in your clinic. Yeah.
What's the frequency of doing 2 knees at a time?
The question is, what is the frequency of replacing 2 knees at the same injections or replacements? Replacements, 2 knee replacements at the same time or 2 hip replacements at the same time. In the US, it's about 5%. It's kind of practitioner dependent. So 2 hip replacements, if you have 2 bad hips, they're equally bothering you. You're going to have them otherwise. You're otherwise healthy. I have no problem doing 2 hip replacements if people want to do it. 2 knee replacement, it has to be the right kind of person. Usually they will come to you asking for it. That is probably the most pain that we're allowed to inflict on another human being. That is really tough to recover from. And it takes a certain mindset to be like, I'm going to do this and be done with it. So most of us, it's kind of a little bit of a feeling the patient out and seeing if they're psychologically able to handle that. It's true, it is psychological. But the other thing would be no history of blood clots and no history of cardiovascular disease. So they can't have any heart problems. It's a bigger, longer surgery. So it's going to be a little more stress on the body. So there is, if you look at the bilateral simultaneous versus we did one and then one 3 months later, a little higher rate of sudden cardiac death if you do both at the same time. Now that overall rate is like 0.01% versus like 0.005, but it's still a little bit higher. Yeah. Yeah.
So you mentioned the joints aren't wearing out now.
Mm-hmm.
So you also talk about
what's the youngest you replace knees on? But, our philosophy has always been to wait as long as possible
Yeah.
to replace a knee.
Mm-hmm.
So how do you talk to the patient about that?
So the question is around, like, if joints aren't wearing out, why are we waiting, or we historically have been waiting as long as we can? Where are we on that? Little bit of nuance. So they're not wearing out because of plastic wear anymore. So they still can fail long term. So knees, for example, we talked about how a lot of them are fixated with cement. So that bond between the cement and the bone may wear out over time and they may come loose. Okay. The failure mechanism of the plastic just wearing through all the way and then needing to replace it, that has gone by the wayside. The most common reason that they fail is still infection. Knees especially still infection. Second most common reasoning being aseptic loosening, which just means not infected, but the implants came loose. So there's still reasons that we don't jump to this when you're 20, because even if it lasts 30, 40 years, that means when you're 50, we're doing a revision knee, okay? And a redo knee is never as good as the first one. You have to burn different bridges each time you go back into the knee. If they get a revision knee when they're 50, 20, 30 years, they're getting a second revision. Then you're really kind of running out of options. And so you may be starting this clock on somebody who's going to have an issue when they're 70, 80 years old. So there's still the idea that if your knee is working well, you're functioning okay, there's no reason to jump the gun. We just got to keep you doing the things you want to do. When you can't, we'll do the replacement. We're a little more cavalier with hips, admittedly, because hips do last better. They last longer, and people get back to no issues typically with them. Knees are always like, you ask somebody if they had a replacement and they've had a knee replacement, they'll be like, yeah, I've had a replacement. You ask somebody who's a hip replacement, they'll think about it for a second, like, oh yeah, I had a hip replacement. People going through the airport with hips will forget what they've had that had metal in them. People with knees will always be able to tell them. So, yeah. Yeah.
What are your thoughts on the hemiarthroplasty? When is that appropriate, or when is it just another procedure?
So the question is, what hemiarthroplasty, when is that appropriate? So hemiarthroplasty, if you, it's a little too far back, but hemiarthroplasty would be, instead of doing the socket and the ball side of a hip replacement, we're just doing the ball side and leaving the socket alone. So the cartilage on their socket would be their own. Almost exclusively reserved for elderly fragility fractures now.
How about in the knee?
Hemiarthroplasty, you mean like a partial knee replacement? Yeah, so partial knee replacements in the knee are a little bit different. So that would be, there's 3 compartments and you could only replace one of the compartments if you wanted to. So the medial would be the most common, second most common would be the patellofemoral joint, and the least common uni would be a lateral joint. Those are done in situations where they only have arthritis in one place, and that's where their symptoms are located. We're pretty stringent about the other places have to look pretty good, because the most common reason they fail is the other places wear out. So if you do a medial uni, they could be back 5 years if the rest of their knee wore out in the same fashion. So you really want to have a pristine joint other places. It's about 10% of people that come in are candidates for a partial. That's usually in a community practice, not usually at the academic practices. Most of us don't really see those patients that early, or they're not getting to us that early. So we don't do that many in our group, admittedly. Yeah. Yeah.
Isolated patellofemoral replacement, is that anything new coming there?
In this, like,
PF joint?
Yeah, I mean, it exists. I love doing that surgery, and it's hard to find those patients because that isolated patellofemoral issue is pretty uncommon. It's usually women 40s and 50s that's that demographic with anterior knee pain their whole life, or maybe instability. They actually do really well. The trouble is the longevity of them, because again, people do kind of go back to other parts start wearing out, and then you have to convert it to a full knee replacement. But some of my happiest knee patients have been patellofemoral replacements. Yeah.
How about the total knee replacement individual who's working? What's the post, like, when do you get them back? It probably depends on what their occupation is, but what does it look like, kind of rehab wise, for when they're getting back to work and that
Yeah.
kind of thing?
Yeah, that's a really good question. So after a joint replacement, when can you get back to work? So it totally depends on occupation, like you're saying. So my usual spiel to people is for the first 4 weeks, I don't really want you doing too much. I want you resting. Just let yourself recover. The second 2 months is when you start getting your function back. And by 3 months, I want you doing everything that you want to do again. So it may not be pain-free, but you should be able to do the things you want to do again by that 3-month-ish mark. So how that goes to occupation is most of the occupations when you're on your feet all day, you're not going to be happy until you're about 3 months. So like nurses, chefs, other people that are on their feet all day, it's about 3 months that you probably need to take off. Now, the flip side of that is people that are like self-employed and they're like, I got to be back as soon as I can. Like, what's the minimum? The bare minimum would be about 2 weeks. So people do go back at 2 weeks. Usually they have to have accommodations that they can sit, they can get their leg up, they got to be able to ice. But usually 2 weeks they're off of the kind of mind-altering meds and can go back to doing things if they're like, that's the lawyers and the judges and stuff like that. Yeah, doctors. Yeah.
Just along that question, what I find is that when they do go back to work soon, and because they have to, they stop doing their rehab. And they don't do as well.
Yeah.
Because they don't have any time for it anymore. And I tell them that ahead of time.
Yeah.
I'm like, this is why I wouldn't.
Yeah, knees especially are kind of like, I think if you talk to knee patients, the difference in a lot of experiences is kind of how much they dedicate to the knee for a few months. If you're icing, you're elevating, you're resting, you're doing the therapy exercises, in general, by 3 months, you'll be doing okay. The people that are at 3 weeks and they're like, hey, I went to dinner with my friend and my knee's so swollen and I'm really painful. Like, what's up? It's like, well, we told you to sit on your butt for, the first month. That's why it hurts. So there's a big difference in kind of that early period based on how easy you're taking it. Yeah. Right. Yeah. Sorry, I'll get you. I keep seeing it. Yeah, go ahead.
I pay a fair amount of attention to this, and the comment that you made about returning to that the knees don't do as well because of the kind of proprioceptive of the feel.
Yeah.
I have not heard that. That's interesting. I heard stability.
Yeah.
But are those the same that you're talking about?
Yeah. I think the question is, not getting back to activity with knees, is that a proprioception thing, or heard in the past that it's stability? I think those are all under the same bucket. So knee is a much more complicated joint. We think of it as just a hinge. It's not a hinge. It rotates, it rolls back, it does all these different things. There's another joint in the front of it that's kind of a pain in the butt, the patellofemoral joint. So all these things kind of come together to when you take a step or you're moving through, there's a ton of stuff happening in a knee. And when you lose your ACL, your PCL, your menisci, you lose the ends of the bone, your brain's losing a lot of signal of like what's happening in there. The hip joint is a much stupider joint. It's just a ball in a socket and it doesn't do anything. So it just sits in there. So like all your muscles are still there, your capsule's still there afterwards. So it's just a much more kind of natural joint for a replacement. So the knee, like it is just kind of, it just doesn't feel right. Like it doesn't hurt anymore. Like I can do it, but it's just like, I don't have that confidence that it's going to be there when I'm cutting. So people can ski, they can play doubles tennis, they can do these things, but really like aggressive stuff. If they're still doing that and they're like, my knee hurts, I need a knee replacement, I'm talking them out of it. And I'm telling them, not until you're not doing that, you shouldn't have a knee replacement. Yeah. I think behind you maybe first.
Is there ever time you choose to do a cluster for a hip, and if so, does it have longer term restrictions?
Yeah, can of worms there. So the question was, do we ever do posterior approach? Yes, we still do posterior approach. So the approach question from hips, your patients will ask you, there's 3 main ways that hips are done: anterior approach, or direct anterior, or DA, a lateral based approach, or a posterior approach. Lateral and posterior are both incisions on the side of the hip. Posterior used to be the kind of workhorse that everyone did forever for 30 years. It works really well. Very extensile. We can do anything through it. We can fix anything through it. Anterior came about maybe about 15 years ago in vogue and is now the dominant approach in the US. Most of us will do anterior approaches for primary replacements. Disadvantage of an anterior approach is that we can't usually do things back through that same incision very well. So it's not great for redoing things. So a lot of times we'll still do posterior approaches for revision surgery. So I do a ton of posterior approach still because we're doing a lot of revision surgeries or redo surgeries. Other times we'll do it as if they have a lot of deformity and we need to do a lot of different things that's not just a straightforward hip replacement. We will do through a posterior approach. In the US, about 60% are DA primary, 40% are posterior. Most people don't do lateral anymore. The long-term outcomes, no difference. There is no difference after 6 weeks between any approach. If you look at the data, you objectively randomize people, there is no difference. So patient websites, implant companies, all these people will tell you otherwise, and anecdotally will tell you otherwise because most patients get anterior hips and most patients do really well. So that's a lot of good spokespeople for an anterior hip, but most people did really well from a posterior approach in the past too. So if a patient gets a posterior approach, it can be for body habitus reasons, it can be for deformity, it can be for complexity. Some surgeons still do that as their primary approach. I would not by any means say that they got posed. They can still have a very good outcome. Their first 6 weeks, they may be a little shorter time off walkers. They may be a little shorter time to do stairs, may need a little more pain medication, but the long-term outcomes between them when we actually do good studies is no difference. Yeah. They do have precautions from posterior hips for those first few weeks. Yeah. But I'm a DA. I love doing anterior approach. I think that's the best surgery in medicine. But you can still do a posterior approach, and I still do. Other questions? Yeah.
Partial, like, it's falling out, they got partial unexpectedly when they went in, it looked fine. In terms of those like twisting and lateral movement sports, like skiing and tennis, is it reasonable to counsel them? You probably will have a bit more motion than anticipated, or is it still pretty?
Sorry, the question is they had a partial
knee.
in
Look at a partial.
Okay. Yeah.
You know, and they're like, wait, now does this mean that I can do more of those activities?
Yeah, usually, I mean, partial knee replacements were actually designed for older, lower activity level patients, and then it got kind of stolen by the younger, more active patients. So it is a more natural feeling knee. It's a quicker recovery. It's a little bit easier recovery. And people do get back to doing a little bit more aggressive. So it's almost become kind of a bridge surgery that we kind of do it as like, we'll do this for a few years and then we can do the total later. So they do usually do a little more active on them. Yeah. Yeah, with partials, the ligaments are all retained. Yeah. And that probably goes partly to feels more stable. You can do a partial knee replacement without an ACL. A lot of people live without ACLs. You cannot do it without any of the other ones. Yeah. 2 minutes? Okay. We got 2 minutes apparently, so get all your questions in. I won't go through any of this stuff. You don't want to. Yeah.
What's the satisfaction rate on those?
Satisfaction rate. So it depends on what you're just defining as satisfaction. If you look at gradating or separating them into very satisfied, partially satisfied, not satisfied, is about 85% of them are very satisfied for a knee replacement. That means 15% are kind of in those other groups that aren't very happy. So that's not great. It's good, but it's not great. Hips are more in the like 95, 98 plus. There's definitely people. A lot of that comes down to expectation management. So like a lot of people will come in and do a surgeon. They'll have a little bit of arthritis. They'll say, let's do a total knee replacement. You'll be running, you'll be doing all these things. And then when they can't, they get very unhappy and say there's something wrong with it. And so as a revision practice, that's a lot of our job is like, hey, this is kind of what it is. This is the limitations of what we're able to do. But yeah, there's definitely a degree of knee replacements still have a ways to go. Good question. Yeah. I keep going. We'll keep going until they take the mic away. Yeah. Hyaluronic acid is if someone comes in and they have a bad arthritis and they're like, what should I get? I usually will just say, if you want something that's definitely going to work at least a little bit, just get a steroid. Everybody gets something from the steroid typically. HA is more hit or miss. Some people will be like, I got nothing from that. Other people will be like, that was great. Some people will actually be like, that was horrible. It made my knee worse. So HA is a really uncomfortable injection in my experience. Patients just don't like it. They have to get through a few weeks afterwards of like, this is kind of worse before it gets better. So all things being equal, I kind of just use steroids. I use HA more in the patients that I'm like, you're not really a surgery candidate yet. I'm going to just, if we're going to try something, we're going to do HA because I know it's not going to kill the cartilage. That's usually where I'm using that more often, if insurance allows it. PRP, I don't do it. Our colleagues do, and so sometimes we'll send them downstairs to get that if that's something they're interested in, but we always tell them, like, you're going to have to pay for this out of pocket. Stem cells, I didn't really get to that, but I would say if they're not in a trial, they should not be getting stem cells. If you're not in a medical trial, would strongly discourage from getting a stem cell injection. Yeah. Okay. Cool. Thanks, everybody. My email is just jeff.berry@UCSF. So if anybody has questions or patients, you're welcome to email me anytime. Thanks, everybody.